Hello everyone, this is Dr. Arpita Dube, a pediatrician. Today we are going to learn about neonatal seizures. So neonatal seizures. Seizures occur more frequently in the neonatal period than at any other time of life. The most frequent and distinctive clinical manifestation of neurological dysfunction in newborn infant is seizures. Seizures cause a high risk of death during the neonatal period, as well as they lead to neurological impairment or epilepsy disorders in later life. Vast majority of neonatal seizures are symptomatic of underlying disorders. Mortality has reduced to 20% from 40% over the years. But the prevalence of long-term neurodevelopment sequelae is still high at 30%. Let's have a look at the figures. According to the National Neonatal Perinatal Database, NNPD, year 2002-03, incidence of neonatal seizures is 10.3 per 1,000 live births. Incidence is found to increase with decreasing gestation and birth weight. Incidence in preterm neonates is almost twice when compared to the term neonates. Incidence in preterm is 20.8 per 1,000 live births. Incidence in term newborns is 8.4 per 1,000 live births. Incidence in low birth weight newborns is 36.1 per 1,000 live births. So how do we define seizures? Seizures is defined clinically as a paroxysmal alteration in neurologic function, that is motor, behavior, and or autonomic function. It includes epileptic, non-epileptic, and EEG seizures. Now, what are epileptic seizures? Epileptic seizures are associated with abnormal synchronous discharge of cortical neurons, that is, corresponding EEG seizure activity. Example, clonic seizures. Then what are non-epileptic seizures? These are clinical seizures without a corresponding EEG correlate. For example, subtle and generalized tonic seizures. What are EEG seizures? EEG seizures are abnormal EEG activity with no clinical correlation. There are 4 major types of neonatal seizures: subtle seizures, clonic seizures, tonic seizures, and myoclonic seizures. So, subtle seizures. Subtle seizures are the commonest type of newborn seizures. They constitute 50% of all the seizures. The clinical manifestations are mild and often missed. Some examples include ocular, oral, facial, lingual movements, limb movements, some autonomic phenomena, and apnea. So, subtle seizures. Tonic horizontal deviation of eyes or sustained eye opening with ocular fixation or cycled fluttering. Oral, facial, lingual movements, chewing, tongue thrusting, lip smacking. Limb movements like cycling, pedaling, boxing jabs, and autonomic phenomena in the form of tachycardia or bradycardia. Apnea is very rare, particularly in term neonates, associated with tachycardia rather than bradycardia and or pupillary dilatation. So here I would like to explain you something. Usually we encounter apnea of prematurity, which is seen in preterm newborns, and it is associated with bradycardia. But apnea due to seizures, due to subtle seizures, first of all, it is very rare. Then it is particularly seen in term newborns, and it is associated with tachycardia rather than bradycardia. There may be or may not be pupillary dilatation. Now let's go to clonic seizures. What are clonic seizures? Clonic seizures may occur unilaterally, sequentially in different limbs, or simultaneously but asynchronously. They involve rhythmic movements of muscle groups. They are biphasic. What do we mean by biphasic? It means they have got two different phases. So there is a fast contraction phase and a slower relaxation phase with a frequency of 1 to 3 jerks per second. Clonic seizures, they may be focal or multifocal and commonly associated with EEG changes. They may involve face, upper or lower limbs, eyes, or trunk. But the most beautiful thing about clonic seizures is that they carry the best prognosis. And among clonic seizures, focal clonic seizures have the best prognosis. Let's go to tonic seizures. What do you mean by tonic seizures? There is sustained flexion or extension, either of axial or appendicular muscle groups. They may be focal or generalized and may often resemble decerebrate or decorticate posturing. In generalized tonic seizures, we do not find any EEG changes. Myoclonic seizures. Myoclonic seizures, they manifest as single or multiple lightning fast jerks of the upper or lower limbs. They have a very rapid frequency and there is an absence of slow return. It usually involves flexure muscle groups, and we see common EEG changes like burst suppression pattern, focal sharp waves, or hips arrhythmia. Myoclonic seizures carry the worst prognosis in terms of neurodevelopment outcome and seizure reoccurrence. Now let's see what are the causes of newborn seizures. First and foremost, the most important cause is hypoxic ischemic encephalopathy or HIE. Then comes focal infarction, which may be arterial or venous. Intracranial hemorrhage like intraventricular hemorrhage, parenchymal, subdural hemorrhage, subarachnoid hemorrhage. They also cause neonatal seizures. There may be infections like meningitis, meningoencephalitis due to torch infection or syphilis. They also lead to seizures. Other developmental defects or structural malformations like neuronal migration disorders, cerebral dysgenesis, neurocutaneous syndromes also contribute to seizures. Acute metabolic disorders like hypoglycemia, hypocalcemia, hypomagnesemia, they are very common. Inborn errors of metabolism like amino acidopathies, organic acidurias, and like epilepsy syndromes. Then we come across some epilepsy syndromes like benign familial syndromes, severe neonatal epileptic encephalopathies, and likewise. So these are some of the common causes, some of the causes of newborn seizures. Some of them are very common and some of them are rare. So let's go to the first one, that is hypoxic ischemic encephalopathy. So hypoxic ischemic encephalopathy secondary to perinatal asphyxia is the commonest cause of neonatal seizures. 50 to 60% start within the first 12 hours of life and rest manifest by the next 24 to 48 hours. Subtle seizures are the commonest type. seen in newborn seizures due to HI. Okay. So, newborn stroke or focal infarction. This is the second most common type of, second most cause of neonatal seizures, seen in up to 20% of cases. In focal ischemic lesions like the MCA stroke, that is middle cerebral artery stroke, infant usually appears well. Infant is well looking, but it presents with focal clonic seizures. Then intracranial hemorrhage, it is responsible for 10 to 15% of neonatal seizures. Term newborns, subarachnoid, intraparenchymal, or subdural hemorrhage. So these three, subarachnoid, intraparenchymal, or subdural hemorrhage, are generally seen in term newborns, whereas preterm newborns, they present with intraventricular hemorrhage. This is seen most commonly between day 2 to day 7 of life. Suppose you come across a well baby, term baby, having seizures on day 2 to 3 of life. What will you suspect? It is mostly due to subarachnoid hemorrhage. So seizures occurring in a term well baby on day 2 to 3 of life, the cause is, in most of the cases, subarachnoid hemorrhage. CNS infections. CNS infections are seen in 5% of neonatal seizures. Congenital intrauterine infections like torch infections. Severe cases present early within the first 2 days of life. Postnatal sepsis seizures, they occur after 48 to 72 hours of life. If they are late onset sepsis. Okay, so acute metabolic disorders like hypoglycemia, hypocalcemia, hypomagnesemia, and hyponatremia, they account for 5% of cases approximately. Malformations or structural lesions account for 5%. Cerebral dysgenesis seizures are refractory to medications. So seizures due to malformations, structural lesions, or cerebral dysgenesis are refractory to medications. Inborn errors of metabolism. They contribute to at least 1% of total cases of neonatal seizures. They occur due to accumulation of toxic products of metabolic pathway. Then there are Periodoxyl dependency seizures. They occur due to defect in ALDH7A1 or antiptyrin gene, which leads to accumulation of alpha AASA in blood, urine, and CSF. Then there are folinic acid responsive seizures. So seizures which are refractory to all other treatment, folinic acid or pyridoxine must be tried in those kind of seizures. Then we go to epilepsy syndromes. What are epilepsy syndromes? Benign familial neonatal convulsions, benign idiopathic neonatal seizures, early myoclonic epilepsy, early infantile epileptic encephalopathy, or Otohara syndromes. These are some of the syndromes which come under the category of epilepsy syndromes. So benign familial neonatal convulsions, they usually occur between day 2 to 3 of life, and they are benign. Benign idiopathic neonatal seizures, they are also known as fifth day fits. So they present suddenly, newborns, they present suddenly on days 4 to 6 of life with multifocal clonic seizures. And it may be related to low zinc levels in the CSF. Then Otohara syndrome or early myoclonic epilepsy is associated with refractory epilepsy. Apart from these, there are many causes which uh, are responsible for causing newborn seizures, like polycythemia, maternal narcotic withdrawal, drug toxicity, especially theophylline and doxapram, or accidental injection of local anesthesia into the scalp. It produces fixed and dilated pupils with absence of doll's eye reflex. Okay, so now let us see which type of seizures carry good prognosis and which has the worst prognosis. So seizures due to subarachnoid hemorrhage and late onset hypocalcemia, they carry a good prognosis. Whereas seizures due to hypoglycemia, cerebral malformations, and meningitis, they carry worse prognosis with adverse neurodevelopmental outcome. How to approach a case of neonatal seizures? So first is history. So try to find out the seizure history. Complete description of seizures should be obtained. If possible, ask to get a video recording. Associated eye movements, restraint of episode by passive flexion of the affected limb, change in skin color like mottling or cyanosis or autonomic phenomena should be noted. Should not forget to ask whether the neonate was awake or asleep at the time of seizures. Then, when the timing of seizures. So if a newborn presents with seizures on day 0 to 3 of life, what are the most probable causes? It may be due to perinatal asphyxia, intracranial hemorrhage, or metabolic causes. Day 4 to 7 seizures are probably caused due to sepsis, CNS infections. There are metabolic causes and developmental defects. Don't forget to inquire about the antenatal and perinatal history. So in antenatal history is suggestive of intrauterine infection, maternal diabetes mellitus, narcotic addiction should be noted. Perinatal history of fetal distress, decreased fetal movements, instrumental delivery, need for resuscitation, Apgar score of less than 5 at 5 minutes, and umbilical cord pH of less than 7, with a base deficit of more than 10 milliequivalent per liter should be noted, should be obtained. What to inquire about feeding? If the newborn has a history of lethargy, poor activity, drowsiness, vomiting after initiation of breastfeeds, it is strongly suggestive of inborn errors of metabolism. Late onset hypocalcemia is seen in presence of top feeding with cow's milk. Family history of consanguinity in parents, family history of seizures or intellectual disability, and early fetal or neonatal deaths are also suggestive of inborn errors of metabolism. History of seizures in either parent or siblings in the neonatal period suggests benign familial neonatal convulsions. After history, we come to the examination. So first and foremost, vital signs, heart rate, respiration, blood pressure, capillary refill time, and temperature should be noted. General examination includes gestation, birth weight, weight for age should be recorded. Why? Because they may provide very important clues to the etiology. Seizures in a term well baby may be due to subarachnoid hemorrhage, while seizures in a large for date neonate may be due to hypoglycemia. Presence of dysmorphic features or any obvious malformations, neurocutaneous markers should be noted. Then we come to the CNS examination. Presence of a bulging anterior fontanel suggests meningitis or intracerebral hemorrhage. Detailed neurological examination should include assessment of consciousness, whether the newborn is alert, drowsy, or comatose, whether there is hypotonia or hypertonia, and fundus examination for chorioretinitis. Systemic examination includes presence of hepatosplenomegaly or an abnormal urine odor is strongly indicative of inborn errors of metabolism. Presence of hypopigmented macules or ash leaf spot, they indicate tuberous sclerosis. Then what all investigations to do in a case of newborn seizures? So there are some investigations which are very essential, and there are some additional investigations which can be do over and above the essential investigations. So the essential investigations include blood sugar, serum sodium and calcium, cerebrospinal fluid examination, cranial ultrasound, electroencephalography, and amplitude integrated electroencephalography. Additional investigations include hematocrit, so newborn which are plethoric, which look plethoric. So we should definitely do a hematocrit for them to find out if there is polycythemia. Then serum bilirubin in case of an icteric child, serum magnesium, arterial blood gas. In which cases are we going to do an arterial blood gas? When we are suspecting inborn error of metabolism. So if the child presents with lethargy, vomiting, family history, then it is strongly indicative of inborn error of metabolism. Neuroimaging like CT or MRI, TOT screen, do not forget to do a TOT screen to rule out infections and workup for IEM. CSF examination, it should be done in all the seizures, as seizures may be the first sign of meningitis and we do not want to miss that. CSF examination should not be omitted even if other signs of seizures like hypoglycemia is present. Why? Because both of them may simultaneously coexist. Okay? So CSF study may be withheld if severe cardiorespiratory compromise is present or in neonates with severe birth asphyxia. Additional investigations should be considered in neonates who do not respond to a combination of phenobarbital and phenytoin, or earlier in neonates with specific features. Then imaging, when to go for neuroimaging. Neurosonography is an excellent tool for detection of parenchymal hemorrhage. CT scan helps in detection of subarachnoid, subdural hemorrhage and intracranial calcifications. MRI is indicated in HIE, cerebral dysgenesis, lissencephaly, and other neuronal migration disorders. EEG. So conventional continuous EEG, known as CEEG, is defined as more than 3 hours of monitoring, is considered the gold standard for the diagnosis of neonatal seizures. So what is the gold standard for the diagnosis of neonatal seizures? It is a conventional continuous electroencephalogram, which is known as CEEG. And how do you define a CEG? It is an EEG recording of more than 3 hours of monitoring. And this is the gold standard for the diagnosis of neonatal seizures. It has both diagnostic and prognostic role in seizures. A background activity in both term and preterm neonates indicate a high risk of neurological sequelae, which include birth suppression, low voltage invariant pattern, and cerebral inactivity. Routine neonatal EEG recording is typically of 1 hour duration. Wherever possible, a 24-hour continuous recording is preferred. Now, what do we mean by amplitude integrated EEG? It is a bedside technique for neuromonitoring, and it helps in evaluating the background as well as in the identification of seizure activity. Screen for congenital infections like TOT screen and VDRL should be considered in the presence of hepatosplenomegaly, thrombocytopenia, IUGR, and chorioretinitis. Metabolic screen, which includes blood and urine ketones, urine reducing substances, blood ammonia, urine, and plasma aminoacidogram, serum and CSF lactate or pyruvate ratio may also be done in selective cases. Now, how to manage? So, initial medical management includes the ABC, that is to ensure proper breathing, proper airway and circulation, and to nurse the baby in a thermoneutral environment, to start oxygen, secure an IV access, blood samples to be collected for investigations. A brief history with quick clinical examination should be performed. And now, very important, all these 3 steps should not take more than 2 to 5 minutes. Anti-epileptic drugs should be considered in presence of even a single clinical seizure, as clinical observations tend to grossly underestimate electrical seizures. AEDs should be given if seizures present even after correction of hypoglycemia or hypocalcemia. But before that, we need to correct the underlying hypoglycemia, hypocalcemia if it is present. So how do we correct hypoglycemia? By giving 2 ml per kg of 10% dextrose as a bolus injection, which is followed by continuous infusion of 6 to 8 mg per kg per minute. If hypocalcemia is present, then give 2 ml per kg of 10% calcium gluconate IV over 10 minutes under strict cardiac monitoring. Hypocalcemic infants should receive calcium gluconate at 8 ml per kg per day for 3 days. In case of continued seizures, 0.25 ml per kg of 50% magnesium sulfate should be given IM. So even after correction of hypoglycemia and hypoglycemia, if the seizures persist, then AEDs or anti-epileptic drugs must be given. And they should be considered in presence of even a single clinical seizures, as clinical observations tend to grossly underestimate electrical seizures. Phenobarbital is the drug of choice in neonatal seizures. Dose is 20 mg per kg IV slowly over 20 minutes, not faster than 1 mg per kg per minute. In case of persisting seizures, additional doses of 10 mg per kg may be used every 20 to 30 minutes until a total dose of 40 mg per kg is achieved. Maintenance dose is 3 to 5 mg per kg per day in 1 to 2 divided doses, starting 12 hours after the loading dose. Phenytoin. Phenytoin is the second-line anti-epileptic drug for neonatal seizures in presence of adverse effects like respiratory depression, hypertension, or bradycardia with phenobarbital. Phenytoin is used. It should be diluted with normal saline as it is incompatible with dextrose. Fosphenytoin, which is a prodrug of phenytoin, is safer than phenytoin in terms of adverse effects like hypertension and cardiac abnormalities, and it has got a higher water solubility. 1.5 mg per kg of fosphenytoin is equivalent to 1 mg per kg of phenytoin. Levetiracetam. It is increasingly being used as a first line or a second line anti-epileptic drug in newborn based on its safety profile in older children. It has got very less side effects and drug interactions. Benzodiazepines, lorazepam, midazolam are the commonly used benzodiazepines. Lorazepam is preferred over diazepam as it has a longer duration of action and has lesser adverse effects like sedation and cardiovascular effects. Midazolam is faster acting than lorazepam and may be administered as an infusion. It has less respiratory depression and sedation than lorazepam. Monitoring is needed for respiratory depression, apnea, and bradycardia when continuous infusion is being given. So let's have a look at the treatment pattern or the treatment flowchart. So first, whenever we encounter a newborn with seizures, so first try to identify and characterize the type of newborn seizures. Then secure airway and optimize breathing, circulation, and temperature. Start oxygen if seizures are continuous. Secure IV access and take samples for baseline investigations like sugar, calcium, magnesium, sodium, potassium, ABG, hematocrit, sepsis screen. If hypoglycemic, that is blood sugar is less than 40 mg per dl, administer 2 ml per kg of 10% dextrose as bolus, followed by a continuous infusion of 6 to 8 mg per kg per minute. If blood sugar is in normal range, sample for ionized calcium should be withdrawn. If abnormal, then 2 ml per kg of calcium gluconate, 10% should be given IV under strict cardiac monitoring. If still seizures are persistent, then administer phenobarbital 20 mg per kg IV start over 20 minutes. Seizures continue. Repeat phenobarbital 10 mg per kg per dose aliquots until 40 mg per kg dose is reached. Still seizures continue. Then administer Phenytoin 20 mg per kg IV slowly over 20 minutes under cardiac monitoring. Then the seizures are continuing. Repeat Phenytoin 10 mg per kg per dose. Still the seizures do not cease. Then consider lorazepam or midazolam bolus and midazolam infusion if needed. Consider ventilation. Still seizures continue. Consider other anti-epileptic drugs like Periodoxyl and exchange transfusion. Consider ventilation. Seizures are controlled. Wean anti-epileptic drugs slowly to maintenance phenobarbital. So let's have a look at the various drugs and their initial and maintenance doses. So phenobarbital. So phenobarbital, the initial dose is 20 mg per kg IV. Consider further 5 to 10 mg per kg increments to a total of 40 mg per kg. Maintenance dose for phenobarbital is 3 to 5 mg per kg per day divided in 2 doses. Also, do not forget to check drug levels. Then we go to Phenytoin. Phenytoin initial dose is 20 mg per kg IV. For Phenytoin, it is 20 mg of Phenytoin equivalents per kg IV. Maintenance is 5 mg per kg per day divided twice or 4 times a day. Benzodiazepines include lorazepam, midazolam, and diazepam. Lorazepam is 0.05 to 0.1 mg per kg IV. Diazepam is 0.3 mg per kg IV and midazolam is 0.15 mg per kg bolus. Levetiracetam, the initial dose is 20 to 50 mg per kg bolus. Maintenance is 20 to 80 mg per kg divided twice or 3 times a day. Now, how to deal with seizures that are refractory to phenobarbital, phenytoin, and midazolam. Following drugs should be tried. The first one is lidocaine. Lidocaine, bolus dose of 4 mg per kg IV, followed by an infusion of 2 mg per kg per hour and is tapered over several days. Adverse effects of lidocaine are arrhythmias and hypertension. Lidocaine is not to be administered with phenytoin. Paraldehyde, sodium valproate, vigabatrin, topiramate are other anti-epileptic drugs. So, paraldehyde, the adverse effects of paraldehyde are pulmonary hemorrhage, pulmonary edema, and hypotension. Sodium valproate, it is 20 to 25 mg per kg per dose, followed by 5 to 10 mg per kg every 12 hours IV or per rectal. Sodium valproate causes hepatotoxicity. Vigabatrin is infantile spasms at a dose of 50 mg per kg per day. Topiramate has got a potential neuroprotective effect, has higher volume of distribution, and is used in refractory infantile spasm. So vigabatrin is meant for infantile spasms and given at a dose of 50 mg per kg per day. In case of refractory infantile spasms, we go for topiramate, which has also a potential neuroprotective effect. Then what are the other therapies? Other therapies like Periodoxyl, exchange transfusion, they can also be tried. So therapeutic trial of Periodoxyl in refractory seizures is recommended. IV route is preferred. IM route may also be used. 50 mg per liter, 50 mg per ml IM on 2 sides. It is given. It can cause hypertension and apnea as well. Exchange transfusion, it is indicated in life-threatening metabolic disorders, accidental injection of local anesthetics, transplacental transfer of maternal drugs like chlorpropamide and bilirubin, encephalopathy. Then maintenance therapy. Monotherapy is the most appropriate strategy to control seizures. Baby should be weaned to only phenobarbital at 3 to 5 mg per kg per day. In case of uncontrolled seizures or clinical toxicity, a second anti-epileptic drug should be added like phenytoin, carbamazepine, or valproic acid. Now, when to wean a newborn from AEDs. So newborn is on anticonvulsant therapy. Wean all anti-epileptic drugs except phenobarbitons once the seizures are controlled. Then perform neurological examination prior to discharge. So if the neurological examination is normal, stop phenobarbital prior to discharge. If neurological examination is abnormal, continue phenobarbital for 1 month. Then once again, repeat neurological examination at 1 month. If the repeat neurological examination at 1 month is normal, then taper drugs over 2 weeks. But if the repeat neurological examination at 1 month is still abnormal, go for an EEG. Evaluate the EEG. EEG may be normal or abnormal. If the EEG is normal, taper drugs over 2 weeks. If the EEG is still abnormal, continue drug. Reassess at 3 months. So intractable seizures, they may need lifelong therapy. Consider switching over to other drugs like phenytoin or carbamazepine. Now, what are the differential diagnosis of neonatal seizures? Benign neonatal sleep myoclonus is commonly confused with neonatal seizures. So what are benign neonatal sleep myoclonus? It is the most common entity which is misdiagnosed as seizure. It is seen in term newborn, who are healthy and thriving well. They may be present from birth to 3 months of life. And the beautiful thing about BNSM is that it presents only during sleep. Multifocal jerks are seen in transition to and during sleep. Jitteriness. We may have, and we have already encountered so many infants with jitteriness. So what is jitteriness? It is seen in infants having exposure to maternal substance abuse or medications, in metabolic disorders, hypoglycemia, and perinatal insult. Stimulus sensitive, high frequency, low amplitude with oscillatory movement, which is activated or exacerbated by arousal. These are the characteristics of jitteriness. It extinguishes with flexion of the extremity and gentle restraint. There are no associated abnormal eye movement or autonomic changes in jitteriness. Then apnea of prematurity. Apnea of prematurity is seen in preterm neonate. Apnea is associated with bradycardia. So, all that shakes is not a seizure. Keep this in your mind before evaluating a baby with seizures. Thank you very much.